Medicos. Good day to all of you. So this is Dr. BK for you, and today I am going to discuss about the pancreas. So we all know that pancreas is a very important viscera which is present in the abdomen, which aids in digestion through its secretions, which is called as the pancreozymin and the secretin. Then apart from that, it also secretes a very important hormone, the insulin, which is responsible for the glucose metabolism. Okay, so now with respect to the pancreas, our learning objectives for today will be mainly a short introduction about this viscera, then followed by that the situation of the pancreas, extent of the pancreas, its various external features or the morphology. Followed by that we will be discussing about the various parts, presenting parts of the pancreas, its relations, mainly how it is related to the other viscera, blood vessels, peritoneal coverings and so on. Followed by that, the blood vessels supplying the pancreas, venous drainage, lymphatic drainage. Then finally, we will just touch upon a few aspects on how the pancreas develops, and ultimately I will conclude this session with clinical remarks. Now, first of all, what is pancreas? The term pancreas, which means all flesh. Pan means all. So we all know that pan India, all India. So like that, pan is all and creas is flesh. So it is a soft, fleshy, lobulated organ. So the connective tissue component is actually very minimal or scanty. Okay, there's very less amount of connective tissue, so it is mostly made up of glandular elements and then the duct system which is present to actually collect these glandular secretions. So it is both exocrine and an endocrine organ. So the exocrine part you see here, these are all the pancreatic acini. So their secretions are in the form of zymogen granules. So they mainly secrete pancreatic and one more thing is secretin. So the pancreozymin mainly consists of the elements necessary for the digestion of proteins, lipids and also carbohydrates. So trypsinogen mainly for protein digestion is present here in an inactive form. Then what happens is, once it is released into the duodenal wall, secreted into the second part of the duodenum, becomes active. So that is again by the secretin which is present. So again, inactive bicarbonate ions which are present, and then naturally what happens is they have to be activated, and all this will be again degraded in the ileum as it reaches the ileum, because there everything is absorbed. So these pancreatic acini secrete these pancreozymin and secretin in the form of zymogen granules, and they are transported to the duct system, which opens into the second part of the duodenum, lumen of the second part of the duodenum. Now, in between these exocrine part, we also have endocrine cells, which is in the form of islets. Islet means island. So they are like segregated one part in between the exocrine part. So that is why it is called as islets, islets of Langerhans. So they mainly consist of alpha cells, beta cells, and also you also have the third type of cells, which is also called as the delta cells. So alpha cells mainly secrete glucagon. Then the beta cells, we all know very much insulin. It secretes the hormone insulin. And then there is also one more thing which is secreted by it, is the somatostatin. So all this is responsible for maintenance of the glucose homeostasis. And these islets are more numerous and present or concentrated in the tail part of this gland or organ. So pancreas, near to the tail part, you have lot of islets which consist of the insulin secreting cells. Now, where actually the pancreas is situated? It is situated in the epigastric and also in the left hypochondriac region. So mainly in the epigastric and the left hypochondriac region it is situated. It is nearer to the posterior abdominal wall, behind the stomach. Or behind the stomach we have a space, the lesser sac. So the lesser sac separates the pancreas from the stomach. So the major part, as I told you, it is present behind the stomach. It is a retroperitoneal organ. That means which is covered only by the peritoneum on the anterior aspect. Major part. What is major part is because the tail part is actually peritoneal, because it presents or it is present within the two layers of the lineorenal ligament. Okay, so that part, the tail part is alone is covered by the lineorenal ligament, the fold of peritoneum, a double layered fold of peritoneum. So the extent from the concavity of the duodenum to the hilum of spleen. Okay, so from the concavity of the duodenum to the hilum of spleen, it is lying transversely, and not only transversely it is lying, but also runs upwards and towards the left. So especially the body and then the tail is at a higher level compared to the head of the pancreas. So it is present in a deeper plane from the anterior abdominal wall, behind the stomach and the lesser sac. So it is just present right in front of the posterior abdominal wall. So you are able to see this is the posterior abdominal wall, and the kidneys, suprarenal and the great vessels, the inferior vena cava and the abdominal aorta are all present in the posterior abdominal wall. So just right in front of them it is present. So that is why you cannot palpate pancreas anteriorly, anterior abdominal, per abdominal palpation. You cannot palpate pancreas because it is present at a deeper plane. So not only the pancreas, one more organ is difficult to palpate is your duodenum. Stomach, liver, and then your spleen, coils of intestine, cecum, appendix, all these things you will be able to palpate, or you can hear the sounds. But here pancreas is not possible, and at the same time even the duodenum is not possible by physical examination because it is present at a deeper plane. So lying transversely, it is actually present from the concavity of the duodenum, extension, transverse extension from the concavity of the duodenum to the hilum of spleen. So that's what I told you. From the concavity of the duodenum to the hilum of the spleen is the extension of the pancreas. It is a roughly J-shaped organ. Okay. So roughly it is actually a J-shaped organ. You are able to see here, and obliquely placed. So as I told you, tail is at a higher level than the head of the pancreas. and mostly it extends from L1, L2 to L3 vertebra. So the vertebral level is from L1 to L3. That is the vertical extent of the pancreas. It is the shape of a retort flask, or you call it a retort shaped organ. Retort flask. So the base of the retort is the head of the pancreas. Okay, and then you have a narrow extension from the head. So I hope many of you would have seen the retort flask in a chemistry lab. So their length is approximately 12 to 15 centimeters and weighs around 80 to 90 grams. Now coming to the presenting parts. So far we have seen about the pancreas, what is its function, where it is situated, under which abdominal region it comes, extent and situation, location we have seen about the pancreas. Now coming to the head of the pancreas. Parts, presenting parts, has got a head, then you have a neck, body and tail. So pancreas has 4 parts: head, neck, body and then the tail. The head of the pancreas is that part which is contained within the concavity of the duodenum. So what is present within these parts of the duodenum? Hollow concavity C-shaped duodenum is the head of the pancreas. How do you identify the neck of the pancreas? The neck of the pancreas is identified by the commencement of the portal vein. Okay. So this bile duct, hepatic artery, behind that portal vein. So portal vein actually is formed at the neck of the pancreas. Formation of the portal vein behind the neck of the pancreas. It's a small constricted part immediately following the head. It is present to the left of the head, the neck region. The body of the pancreas extends from the abdominal aorta to the left kidney. So from the front of abdominal aorta to the left kidney is the extent of the body. Tail is that part which is present between the 2 layers of the lineorenal ligament and very closely related to the hilum of the spleen. So that is actually the demarcation between the various pancreatic parts. Okay. Now, junction between the head and neck in front can be demarcated by the gastroduodenal artery. So you can see gastroduodenal artery will be lodging in a groove in the front, that is between the head and neck. Then body, neck and body by the left border of the portal vein. By the left border of the portal vein is the junction of the neck and body. Anteriorly it is difficult to demarcate between the neck and body. Between the body and tail, it is the peritoneal and the non-peritoneal part. Tail is covered by peritoneum, whereas body is not covered by peritoneum. Okay, so that demarcates the body from the tail. So these are the demarcating points between the various presenting parts of the pancreas. Okay, now we will try to understand the relations of each part of the pancreas in detail. Now coming to the head of the pancreas, it is the most widest part and flattened antero-posteriorly. It is flat antero-posteriorly. It has got an anterior surface. It has got a posterior surface. Okay, it has got an anterior surface and behind posterior surface. Then it has got a superior border, right lateral border and inferior border. Okay, superior border, right lateral border and inferior border. So because of this, it is contained within the first, second and third part of the duodenum. The head is contained within the first, second and third part of the duodenum. So 3 borders I told you: superior, right lateral and inferior, two surfaces I told you, anterior surface and the behind is the posterior surface. Then one process you have which is called as the uncinate process. So three borders, two surfaces and one process which is called as the uncinate process. So borders, very easy to remember the borders. Superior border related to first part of duodenum. Related to first part of duodenum and superior pancreatico-duodenal artery. So celiac trunk, common hepatic artery. From the common hepatic artery, what you see is the gastroduodenal artery. The gastroduodenal artery gives rise to a branch that is the superior pancreatico-duodenal artery. So the upper border is related to the first part of duodenum and the superior pancreatico-duodenal artery. The rest of the borders are related to second and third part. So inferior related to the third part and inferior pancreatico-duodenal artery, which is a branch from superior mesenteric artery. Superior mesenteric artery, first branch is the inferior pancreatico-duodenal arteries. Now, the superior pancreatico-duodenal artery will give anterior and posterior branches. What you see here is the posterior branch. The inferior pancreatico-duodenal artery will give posterior branch and anterior branch. So, these antero-posterior branches of the superior pancreatico-duodenal and inferior pancreatico-duodenal, they anastomose in the groove between the head of the pancreas and the concavity of the duodenum. You will be able to see the anastomosis. Okay. So this anastomosis is very important, mainly blood supply to the duodenum as well as the pancreas. Not only that, they are also responsible for supplying your lower part of the bile duct. So that is why in my bile duct class also I told you, while ligating the pancreatico-duodenal artery, you should be careful. If the anastomosis is poor, then the lower part of bile duct might undergo necrosis or stricture formation will take place. Okay. So superior border first part, inferior border is actually third part with superior and inferior pancreatico-duodenal arteries. Right lateral border, as I told you, related to second part and anastomosis between the superior and inferior pancreatico-duodenal arteries. So that is about the borders. So in this diagram, you are also seeing the posterior surface of the head of the pancreas, and you are able to see the bile duct is actually lodged in a groove. The posterior surface, the bile duct is lodged in a groove. The anterior surface, you can see the gastroduodenal artery is lodged in a groove. So that is why it is shown as the dull part, because it is present to the front. Gastroduodenal artery is lodged in a groove in the anterior part of the surface of the head of the pancreas, whereas the bile duct on the posterior surface, it is lodged in a groove. So coming to the other relations, we see about the borders. Anterior surface related to, here you are able to see this is actually the attachment of the transverse mesocolon. So the transverse mesocolon, here you are able to see it's attached. The upper border will go above, the lower border will go below. The splitting of the two layers of the transverse mesocolon. So anterior surface, upper part is related to the transverse colon and transverse mesocolon. Here it comes transverse colon. The lower part is actually related to the coils of jejunum, lower part. So here is the duodenojejunal flexure, then completely the coils of jejunum will fill the whole part. So here coils of jejunum below, above transverse colon, transverse mesocolon, anterior surface relations. Posterior surface, as I told you, posterior surface mainly you can see the bile duct is lodged in a groove. Apart from that, it is related mainly to this inferior vena cava. Then you see the kidney, so naturally the renal vessels, the especially your right renal artery, renal vein. So renal vein, you will be able to see here inferior vena cava and the right renal vein. Sorry, it is given as left, some typographical error. So it is right side and head. So naturally, even left renal vein is possible because left also starts from this side of the left of the midline. So that is why. Then crus of the diaphragm. So this part where you can see the diaphragm as the right crus and left crus. Then bile duct lodged in a groove, which I have shown in the last picture itself. So these are the relations. So mainly you come across the right crus of the diaphragm, bile duct, inferior vena cava. Of course, you can write even this muscle right psoas major. Then gonadal vessels, right, gonadal vessels. That is testicular in case of males or ovarian in case of females. Suprarenal, middle suprarenal vessels. All those things forms the relations of the posterior surface of the head of the pancreas. Mainly remember IVC, renal veins, crus of the diaphragm. The head of the pancreas, lower left part has a process which is called as the uncinate process. It is actually called as the uncinate process. Okay. So this uncinate process present to the left part of the head, and the superior mesenteric vessels, they actually arise in front of these vessels. So the superior mesenteric vessels is present anterior to the uncinate process. The abdominal aorta is present posterior to the uncinate process, and above what we have is the left renal vein. Above you also have what you have is the left renal vein. Sometimes between the superior mesenteric artery and the abdominal aorta, the left renal vein might get compressed. That is called as the nutcracker syndrome. That is called as the nutcracker syndrome. So behind abdominal aorta, in front superior mesenteric vessels is the relation for the uncinate process, which is a process from the lower left part of the head of the pancreas. Coming to the neck of the pancreas. So this part is the neck of the pancreas. As I told you, how do you identify the neck? Behind you see the formation of the portal vein. The portal vein is formed by the union of superior mesenteric vein and the splenic vein. So posterior part of the neck, lower part is related to superior mesenteric, upper part is related to the portal vein. Slightly constricted following the head or to the left of the head, connects the head with the body. It is related, neck of the pancreas is related to, see the stomach has been reflected, so naturally anteriorly it will be related to the pylorus of the stomach. So anterior surface will be related mainly to the pylorus of the stomach. Posterior surface, as I told you, the superior mesenteric vein will join with splenic vein to form the portal vein. So the last slide, what I showed you here is superior mesenteric vein related to lower part of the neck, and portal vein related to the upper part, formation of portal vein behind the neck of the pancreas. Upper border, first part of duodenum, and lower border is the root of transverse mesocolon. So that is the attachment of the transverse mesocolon. Then the transverse mesocolon, it splits into above and below, as I told you. Okay. The above one forms the above continues with the posterior wall of the lesser sac, and below the inferior layer of transverse mesocolon will continue with the greater sac. So that is about the relations of the neck of the pancreas. Next, we will discuss about the body of the pancreas. The body, you can tell it is prism shaped or pyramidal. It has got three surfaces and three borders. Main extension is from the abdominal aorta to the left of abdominal aorta to the left kidney. Okay. So from the front of aorta to the left kidney is the body of the pancreas. Plasmoid, as I told you, it has got a antero-superior surface, antero-inferior surface and posterior surface. Three surfaces, three borders, and superior border, anterior border and inferior border. Okay. So three surfaces and three borders. So it actually passes upwards and then backwards to be continuous with the tail of the pancreas. So three surfaces, as I told you, they are the antero-superior surface. Then you have this surface, antero-superior surface, is actually related to the posterior-inferior wall of the stomach and separated from the stomach by the lesser sac. Between the stomach and the pancreas, the lesser sac intervenes. So all these structures, what you are able to see behind the stomach, you are able to see the pancreas, you are able to see the kidney, renal vessels, splenic artery, all those things, they are all these stomach bed structures. So the pancreas, the body of the pancreas itself is a part of stomach bed structures. So related to the posterior inferior surface or wall of the stomach, separated from the stomach by the lesser sac, anterior or antero-superior surface. The inferior surface or antero-inferior surface is related to duodenojejunal flexure and coils of jejunum, and more laterally you come here, you will have the left colic flexure. So inferior surface, here you are able to see it is related to the duodenojejunal flexure. Then coils of jejunum will be all present here, and then the left colic flexure. Posterior surface behind, it is related to left kidney, left suprarenal, left renal vessels. Okay. Then origin of superior mesenteric vessels. Actually here you are able to see it in front of the uncinate process, but the origin is behind. You can see the body of the pancreas. So left kidney, left suprarenal, splenic vein in a groove. This splenic vein separates the posterior surface of the body of the pancreas. I repeat, this splenic vein separates the posterior surface of the body of the pancreas from left kidney, left suprarenal, left renal vessels, suprarenal vessels, left crus of the diaphragm and left psoas major vessels. This is the left psoas major. This is the left crus of the diaphragm. This what we have seen is the right crus of the diaphragm. Right crus is related to the head, posterior surface of the head. Left crus is related to the posterior surface of the body. So all these structures are separated from the posterior surface of the body of the pancreas by the splenic vein, which is running in a groove. So this splenic vein joins with the superior mesenteric vein to form the portal vein behind the neck of the pancreas. Okay. So the superior border again has a projection which is called as the tuber omentate. So this projection will again face towards a projection in the liver, which is also called as the tuber omentate of the liver. Now to the left of the tuber omentate, it is related to the celiac trunk and the hepatic artery, common hepatic artery, celiac artery and the common hepatic artery. To the right of the tuber omentate, the superior border is related to the splenic artery. So the splenic artery is related to the superior border of the pancreas, more on a posterior plane. Okay. At the posterior part of the superior border of the pancreas, you can see the splenic artery running over the body of the pancreas. So right of tuber omentate is the splenic artery, left of tuber omentate you see the celiac artery and the common hepatic artery. So anterior and posterior surface of the body of the pancreas. Borders, inferior border, superior mesenteric vessels emerge Anterior border is related again to the root of transverse mesocolon. See this attached part? Root of transverse mesocolon. Very beautifully you can see the two layers. Root of transverse mesocolon is attached to the anterior border of the pancreas. Inferior border we have seen emergence of these superior mesenteric vessels, and that is the anterior border. Tail of the pancreas, you are able to see within these two layers, it has gone inside between these two layers, lineorenal ligament. It is the leftmost end of the gland related to the hilum of the spleen. Behind it is related to the left kidney, in front it is related to the left colon flexure. Okay, and as I told you, it is peritoneal, the only part which is actually peritoneal, the tail of the pancreas, the lineorenal ligament. Apart from that, the lineorenal ligament also transmits your splenic vessels. Now, so that is about the presenting parts and the relations. Mainly we have seen about the head, neck, body and tail of the pancreas. So you should mainly remember behind the neck, formation of portal vein. Then tail is present within the two layers of lineorenal ligament. Now pancreatic ducts, the main pancreatic duct usually starts from the left end near the tail. The main pancreatic duct, at regular intervals it receives, mainly you are able to see small ducts it receives throughout its extent, and that pattern is actually called as the herringbone pattern. Smaller ducts are received at regular intervals. So main duct starts from the tail and passes through the body, neck, and naturally is going to come to the head, opens into the major duodenal papillae after turning downwards and right to enter the second part of duodenum and the major duodenal papillae. Before opening, it will join with the bile duct. Here you are able to see the bile duct course, intraduodenal course, and form a dilatation which is called as the ampulla of Vater or hepatopancreatic ampulla, and opens at the major duodenal papillae, which is 8 to 10 centimeters below the pylorus of the stomach. 8 to 10 centimeters below the pylorus of the stomach. So that is the main pancreatic duct of Wilson. Sometimes you also come across this accessory pancreatic duct, also called as Santorini. The accessory pancreatic duct mainly starts from the uncinate process. Okay, lower part of the head, that is near the uncinate process. And then what happens? It runs above, laterally, upwards and medially, and then finally what happens? Crosses the main duct and opens into the minor duodenal papillae. If at all present, it is not necessarily, should be always present, accessory pancreatic duct. If present, passes in front of the bile duct and opens into the second part of duodenum, the minor duodenal papillae 2 centimeters above the major duodenal papillae. So the termination of the bile duct, variations, the termination of bile duct along with the pancreatic duct in the formation of hepatopancreatic ampulla is very common. We have already discussed that in the extrahepatic biliary apparatus class, all the variations I have described. So here just 3 types of variations. So one is you are able to see common bile duct and then pancreatic duct, very short fusion part, that fused part is very short before opening here. Here they have not at all fused, no common channel, they open separately. Here they fuse at a very high level. So the hepatopancreatic ampulla part is very long. So these are the 3 most common type of variations you can see in the termination of the pancreatic duct and the bile duct. So the blood supply of the pancreas, mainly the head of the pancreas, and and the tail and body of the pancreas are supplied by the various arteries. Splenic artery related to the superior border throughout its course gives pancreatic branches, supplies the body and tail of the pancreas. One of the pancreatic branch of the splenic artery is large and called as arteria pancreatica magna. And same way you could be also able to recognize a branch in the tail region called as arteria cauda pancreatica. Most important one is the arteria pancreatica magna. Of the pancreatic branches, this branch will be very large. So pancreatic branches from the splenic artery mainly supply the body and tail. So that is the splenic artery you are able to see from the celiac trunk. On its course to the spleen, it gives out the pancreatic branches. Apart from that, splenic artery will also supply fundus of the stomach. Then it will give left gastroepiploic artery, which also will supply the greater curvature of the stomach. So superior pancreatico-duodenal artery from gastroduodenal and inferior pancreatico-duodenal artery from superior mesenteric. So they both will give anterior and posterior branches which anastomoses and mainly supply the head of the pancreas by the superior and inferior pancreatico-duodenal arteries. So that is about the blood supply of the pancreas. Next, coming to the venous drainage. Of course, through the splenic vein and superior mesenteric vein, they ultimately drain into the portal vein. So corresponding arteries drain into splenic, superior mesenteric, and then you are able to see this is the superior mesenteric, this is the splenic vein. Splenic vein is receiving a tributary which is the inferior mesenteric vein. So behind the neck, the portal vein is formed by the union of superior mesenteric and splenic. So upper part of neck, portal vein, lower part of neck, superior mesenteric vein is related. Lymphatics, mainly tail region, you are able to see the pancreatico-splenic lymph nodes, and here head region you see the pancreatico-duodenal lymph nodes. So heads drain into pancreatico-duodenal lymph nodes, and body and tail into pancreatico-splenic lymph nodes, which are seen along the splenic vessels. So ultimately they drain into celiac nodes and superior mesenteric nodes. Okay, celiac, superior mesenteric and pre-aortic nodes. So that is the lymphatic drainage of the pancreas. Development of pancreas. A brief description about the development mainly develops from two sources, dorsal and ventral pancreatic bud. So here you are able to see the dorsal pancreatic bud, and here you are able to see the ventral pancreatic bud. Ventral pancreatic bud arises in common with the hepatic bud and cystic bud. You are able to see. So this is actually the junction of foregut and midgut. So at the junction of foregut and midgut, you see the dorsal and ventral pancreatic bud. So the dorsal pancreatic bud from the dorsal wall of the foregut grows into the peritoneum of the duodenum, which is called as the mesoduodenum. Then what happens is slowly the mesoduodenum loosens, the duodenum loosens its peritoneal covering through zygosis, because what happens is initially what happens, it is a simple tube, and this tube has a convexity towards the front. It is not C-shaped. Finally only it acquires a C-shape. First it is actually convex to the front. When the stomach rotates, when there is a rotation of the stomach around the vertical axis, this convex C-shaped which is to the front gets turned and approximated towards the right side. So since it is fixed to the right side to the posterior abdominal wall, it loses its mesoduodenum and becomes retroperitoneal. So it is actually secondary retroperitoneal. Initially it is inside the peritoneum, loses its peritoneal covering and becomes retroperitoneal. So that is the dorsal bud. Ventral bud appears in common with the hepatic bud and grows into the ventral mesentery. Now, as I told you, when the duodenum rotates, the C-shaped duodenum, which is convex anteriorly, and when the stomach rotates, what happens is this convex part, which is to the front, will rotate towards the right side and get fixed to the posterior abdominal wall. Okay, so during this rotation, not only that, the right wall of the duodenum grows faster, enlarges. This right wall of the duodenum grows larger and enlarges. So thereby what happens is, as this is enlarging slowly, the ventral bud, which is situated here, has to migrate or pushed behind and below the dorsal bud. Is pushed behind and below the dorsal bud. So ventral pancreatic bud ultimately comes to lie below the dorsal pancreatic bud. So due to the rapid growth of the right wall of the duodenum. That is how the ventral bud is shifted. Originally which was in front, now comes to lie behind and below the dorsal bud. And it completely fuses with it. So ultimately what happens is, the dorsal bud gives rise to the upper part of the head, body and tail of pancreas. Forms the head, body and tail of pancreas. Lower part of the head, an uncinate process from the ventral bud. So the ventral bud forms the uncinate process and the lower part of the head. How the duct system forms. So that is how the rotation takes place, and due to the enormous rapid right wall of the duodenum grows, the ventral bud is shifted dorsally. With respect to the formation of the duct pattern, main pancreatic duct develops from the duct of the dorsal bud, distal part of the duct of the dorsal bud, duct of the ventral bud, and communication between these two, dorsal and ventral bud. Okay, so duct of the distal part of dorsal bud, then communication of these two, dorsal and ventral bud, and duct of the ventral bud. So this forms the main pancreatic duct. Accessory pancreatic duct, if at all is present, is mainly developed from the proximal part of the duct of dorsal bud. Okay, from the dorsal duct proximal to the communication. So that forms the accessory pancreatic duct. So that is something about the development of the pancreas. Coming to the clinical aspects, annular pancreas. So when the ventral bud and dorsal bud, this is a ventral bud coming and lying below and behind the dorsal bud, it completely encircles the duodenum, which is called as annular pancreas. Surrounds the second part of duodenum, so it might compress the second part. Naturally, the bile duct gets compressed, and you might get obstructive jaundice. Okay, so again, compression of the bile duct, we have discussed the extrahepatic biliary apparatus, whether it's an extrinsic factor, mainly due to annular pancreas. Intrinsic factor might be due to the gallstones or stricture formation within the lumen of the bile duct. Pancreatitis, so inflammation of the pancreas. Inflammation of the pancreas might be due to so many reasons. What is alcohol, or sometimes it may be due to drugs or trauma. So all these things might lead to inflammation of the pancreas. Pain is mainly felt in the epigastric region. It might radiate to the back. Okay, it might radiate to the back because it is situated in a more posterior plane. So acute and chronic, two types of pancreatitis we come across. So in inflammation, if it is spread to the lesser sac, it might produce a cyst, and naturally what happens, it might form adhesions in the lesser sac and close the lesser sac, which appears like a pseudocyst behind the stomach. So this is the liver and spleen, this is your stomach, which you are able to see here. And here, what you are able to see here is the pseudocyst of the pancreas. So it is the lesser sac, due to adhesions, it is closed on all sides. So carcinoma, again, pancreatic carcinoma most common in the head of the pancreas. So even chronic pancreatitis, what happens is might become carcinoma, might become cancerous at one stage. Mostly affects the head, and usually the carcinoma starts from the duct system. So that is also next most common is the duct system, where the carcinoma starts. Again, it may compress the bile duct, producing symptoms of obstructive jaundice. Then apart from that, you have weight loss, loss of appetite, all those things. Pancreatitis, again pain, you have tenderness, fever, all those things. So pancreatitis not only acquired, it might sometimes it might also be autoimmune due to some autoimmune conditions, auto destruction might take place. So compression, cancers of the head of the pancreas, bile duct it might compress the portal vein leading to ascites, or it might compress the pyloric sphincter. So pyloric opening might also be compressed. In certain cases, the enzymes the pancreatitis, the enzymes might be released within the pancreas itself. So mainly trypsinogen is considered an inactive form, but sometimes it might get activated if it is released within the pancreas itself. It might destruct the pancreatic cells, which is actually called as the auto-digestion of the pancreas. So I have seen mainly about annular pancreas, then we have seen about the pancreatic carcinoma, pancreatitis, and auto-digestion of the pancreas. So that is all about the pancreas. Thank you very much for your patient listening.